Welcome to HIV Updates 2018, Evaluating New Therapies. This is a session jointly provided by the North American Center for Continuing Medical Education and DKB, supported also by an educational grant from Gilead Sciences. I'm Ethel Weld. I'm an assistant professor of clinical pharmacology and infectious diseases at Johns Hopkins University in Baltimore, and I'll be jointly presenting with Dr. Mona Chitre, who's Chief Pharmacy Officer for Excellus Blue Cross Blue Shield in Rochester, New York. Allison Agwu is an Associate Professor of Adult and Pediatric Infectious Diseases at Hopkins, who has also contributed to content. And our disclosures are listed there. The educational objectives of this talk are really to recognize populations within the U.S. to be screened for HIV and to incorporate the current guidelines from the United States Preventative Services Task Force, to compare some of the newly available medicines that are recently approved by the FDA to their older counterparts, and to discuss some therapies that have proceeded through early phase development and are now in late phase that will be emerging on the market soon. We will be identifying both existing and in development HIV therapies that are likely to appear soon in HIV treatment guidelines in advance of the final FDA labeling as well. And we wanted to provide you with some definitions because we know a lot of this can really seem like alphabet soup at times, but these are some slides with definitions of acronyms just for your reference throughout. You can come back to these. So the first section is to discuss HIV epidemiology, testing, and demographics, and this is with a focus on the United States. So this slide presents the subpopulations most affected by HIV in the United States, and you can see this is data from 2016, that the majority of the epidemic is born among MSM in terms of incident HIV, and in the 20 to 29 age group is accounting for a large spike in HIV diagnoses in the United States. People who inject drugs account for about 7% of the epidemic now, and 41% are less than 30 years old. This is the estimate of the total burden of HIV in the United States, a bit over 1 million cases, and it's an epidemic that has been shifting over recent years because of advances in therapy, to the point where 27% of patients who have HIV in the U.S. by the year 2035 will be greater than 65 years old. And with that comes comorbidities, so 44% of them have 3 or more other comorbidities apart from HIV. So here you see demographic breakdown of cases of HIV in the United States. These are the guidelines for HIV testing in the U.S. So the recommendation is for everyone between 15 and 65 years of age that they be screened for HIV. For everyone who is pregnant, whose HIV status is not yet known, they must be screened, and they must be screened with every new pregnancy. And then there is more frequent screening than yearly for those at increased risk of HIV. For example, men who have sex with men, youth, people who have at least semi-habitual habit of injecting drugs, those who have TB or other sexually transmitted infections that can go along with HIV, and those who are taking pre-exposure prophylaxis against HIV. So that screening recommendation is every 3 months for some of those groups, and of course as clinically indicated. The interval is not really explicit in the guidelines, but the CDC did conclude that there's not enough evidence to support greater than annual screening for MSM in 2017. So annual screening for MSM is their current recommendation unless there's some specific risk that occurs. So there is basically a drive towards routine testing that's offered routinely to everyone as part of a system of care, and it's not only based on perceived risk, because that stands to miss proportion of people who are infected. The current testing strategies that are in place lead to the fact that significant numbers of people are identified at later stages of disease. mostly because individuals who do not know that they have HIV account for greater than half of new sexual transmissions of HIV. It's of interest to know how many people do not know their serostatus, and 1 in 7 people with HIV in the U.S. do not know their status. 1 in 2 youth between the ages of 13 and 24 who have HIV do not know their status. And this is important because people's risk behaviors do change once they know they are infected. So earlier testing leads to earlier diagnosis. The earlier you're diagnosed, the earlier you can be linked to care. And this helps not only the individual, but is a step in blocking transmission for the community. Because if that individual's viral load is down, their risk of transmitting to someone else is lower. This led to the idea of undetectable equals untransmittable. So that's the U equals U campaign, which is a broad movement that arose out of advocacy and also directly from the science. The partner study, HPTN-052, showed that among HIV discordant couples, one of whom was infected and the other of whom was uninfected, there was a dramatic reduction in HIV transmission when the HIV-infected partner was treated with antiretrovirals and became virologically suppressed. This was later borne out in other populations in the opposite attract study, which looked at serodifferent couples and men who have sex with men. And there's not been one single phylogenetically linked transmission if the HIV positive partner's viral load was undetected below 200 copies per ml. So this campaign is intended to reduce stigma in the community that's long been associated with this disease. The WHO and DHHS guidelines, therefore, both recommend ART for the prevention of transmission of HIV, so not just for the benefits it gives to the individual who has HIV. So this depicts the cascade of care in the United States. So out of the 1.1 million people living with HIV in this country, about 85% of them are diagnosed, 62% of them are linked to care, 48% retained in care, and 49% virally suppressed. So a lot of challenges in reaching the undiagnosed and linking to care the diagnosed. There's, of course, room for improvement. This figure shows mortality and antiretroviral use over time. So you can see these are slides from the CDC covering the early antiretroviral era, depicting that the number of deaths per 100 person years dramatically fell as the number of patients with uptake of highly active antiretroviral therapy increased. And that's borne out in a slightly different visual display in the upper right-hand corner. Lifespan among those with HIV in the late antiretroviral era is depicted in this blue chart below. So this depicts the life expectancy in Europe and North America between HIV positive and HIV negative individuals. So a man who is HIV positive is expected to live on average 73 years, whereas a man who's HIV negative, 77 years. For women, the HIV positive live an average of 76 years, and the HIV negative live an average of 81 years. So you can see that there is near convergence of lifespan between those who have HIV and do not have HIV. The causes of death among those who have HIV are the majority of the time non-AIDS related. They are malignancy, liver failure, often associated with hepatitis co-infection, infections that are not AIDS related, heart disease, neurocognitive disorders. So overall, the thing that ends your life if you have HIV is no longer HIV, it's a comorbidity. So just to move on to a discussion of current and emerging therapies for HIV. To talk about the moment when you would choose a new regimen and why. So one of the reasons for choosing a new regimen would be for initiation of treatment in a patient who is treatment naive. Another reason would be if you have a patient who's been on therapy for a while but who needs a switch of regimen due to treatment failure. And it's always hard to tease out whether that is because of adherence concerns, they just can't manage to take the regimen, or because of resistance of their virus to the medicines they're being treated with. Side effects and toxicity can certainly necessitate a switch, especially if you have a component of the regimen you're treating them with that is known for that toxicity. If someone has virologic suppression and is doing well, but you have concern that they may intermittently have adherence struggles and be at risk for developing resistance, and you have an emerging availability of a more potent drug that has a higher barrier to resistance, that would be a very reasonable cause for changing a regimen. In addition to developing new comorbidities such as hepatitis B that need their own treatment in a co-treatment manner with HIV. So the factors that would influence your regimen choice for someone who's never been treated for their HIV before are many. You think about pill burden, you think about the size of the pills, the number of pills, the number of times a day someone has to take a pill, the amount of trouble the person you're dealing with might have taking medicine several times a day, drug-drug interactions, and I want to plug this HIV drug interactions checker here that I provided the link for. It's from the University of Liverpool website, and it is incredibly helpful when you're starting a regimen to run it through the interactions checker, not only to understand what the kinetic interactions are between the drugs, but also whether they are clinically meaningful for your patient. Thinking about side effects and long-term toxicities, if you have someone who has vulnerable kidneys already, you might want to stay away from medicines which in a cumulative fashion affect the kidneys. If someone is pregnant, you take into consideration their likelihood of transmission to the fetus and which drugs have been studied in pregnancy. You take into account their baseline CD4 count and viral load, and whether they have certain predispositions that are genetic towards hypersensitivity to components of an HIV regimen. One of those is the HLA-B5701 allele, which if you inherited this gene signature, you're at increased risk of developing hypersensitivity to abacavir, which is one of the main NRTIs in the nucleoside reverse transcriptase inhibitor class to treat HIV. And all guidelines agree that if you are HLA-B5701 positive, you should not get abacavir. The DHHS recommendations for initiating ART are depicted here. Basically, older recommendations split this up by CD4 cell count level. The current recommendation is that all individuals with HIV, regardless of their count, be treated with ART, and it is recommended as a transmission prevention step for others. And embracing and adopting strategies to increase adherence is of critical importance. The language of the recommendations from both the DHHS and the IAS of note will transition to people first language, which means referring to people with HIV or people living with HIV instead of HIV-infected patients. So there are some factors that are going to increase your urgency to start ART. If someone is pregnant or has high pregnancy potential, i.e. is a woman of reproductive age not on an effective contraceptive who is sexually active, you will definitely want to start her on ART sooner rather than later, again, to decrease the possibility of maternal to child transmission. If someone has AIDS-defining conditions, including various opportunistic infections, but also AIDS-associated malignancies or neurocognitive illnesses, then there is urgency to treat with antiretroviral, which can reverse the progress of many of those diseases. Those whose disease has progressed further, who are at a later stage of illness with lower CD4 counts and potentially some end organ damage from HIV, such as HIV-associated nephropathy, there's an urgency to treat them. Any sort of infection that you think might be an acute HIV infection, perhaps the acute antiretroviral syndrome, would be urgent to treat as soon as you've identified it. And then those with hepatitis B or C co-infections, since their morbidity is so high. There is high complexity in the HIV drug market. There's 8 drug classes, new classes really emerging every year, and then greater than 40 products. They're depicted here for your reference. I won't go into every drug mechanism because it's not the focus of this talk, but just to say that there are many choices to make when treating someone with HIV. So these are the Department of Health and Human Services 2017 guidelines on what to start. And the box in yellow indicates what these recommendations consider the first-line regimen. So Dolutegravir, abacavir, and 3-TC is a first-line regimen if their HLA-B5701 gene signature is negative. Dolutegravir combined with tenofovir and FTC is considered line, and as is elvitegravir that's cobicistat boosted, and raltegravir. Now, one thing about these guidelines is that they are somewhat agnostic as to which is better between TDF and TAF, and that's something they don't have in common with the IAS guidelines, which puts TAF FTC-based combinations more prominently first line. The boxes below are advisories and warnings that emerged after these guidelines came out, so just to keep you abreast of how they have evolved and changed since they were released. The second box basically is just adding the fixed-dose combination product of bictegravir, tenofovir, alafenamide, and emtricitabine as one of the first-line recommended initial regimens for people with HIV, so it belongs in the yellow box, and it will be in the next version. And then there's something that came out May 18th of this year, which has generated a lot of discussion and a lot of buzz, basically about a potential safety signal of an increased rate of neural tube defects in infants born to women participating in a trial of dolutegravir and other antiretrovirals in Botswana. So those are being investigated, those findings are being rigorously analyzed, and what to make of those findings is to a certain extent up in the air. But there's been interim guidance released basically stating that women of childbearing age who are trying to become pregnant or wishing to become pregnant should discuss alternative regimens to dolutegravir, and pregnant women who are already on dolutegravir should not stop it and should just discuss with their provider next best steps. It's of note that it's not understood yet whether this is a clear signal that's been reproducible, and it's not understood whether this would be a class effect across the integrase strand transfer inhibitors or something peculiar to dolutegravir if it is indeed a signal. The next slide just goes into recommended initial regimens in certain clinical situations. So, for example, if your baseline viral load is less than 100,000 copies and your baseline CD4 before treatment was greater than 200 cells per cubic centimeter, then you would be appropriate for a rilpivirine-based regimen, and you would be appropriate for raltegravir-based regimen with abacavir 3-TC, for example. But taking into account if someone has a higher viral load, higher than 100,000 copies, that's someone who should not be getting a rilpivirine-based regimen out of concerns for virologic failure that emerged out of the trials. So the regimen choice based on pre-ART characteristics is depicted in this slide. And just to further highlight, if you have someone who's come to you with acute HIV, I've already told you that there is urgency to start antiretrovirals in that situation, both because you reduce the transmission of the virus, which is easy to transmit in the acute setting because it's many logs higher in terms of viral load than at other stages of the disease, and because it benefits that individual because of affecting the establishment of the latent reservoir and other factors. That means a rapid initiation means you initiate antiretrovirals the moment you see a person without waiting for genotypic information and lots of testing to come back. And the recommended ART regimen in that situation, both in acute HIV and in rapid initiation, not otherwise specified, where you just basically initiate the second you find out that they are positive, is a regimen with a very high barrier to resistance that would be an appropriate treatment even if they had a slightly resistant virus. So that would be a PI-based regimen with darunavir that is boosted, or a dolutegravir-based regimen. These are the IAS guidelines, again, just to emphasize that they do not consider TDF first line anymore and have incorporated TAF, but otherwise are really fairly similar to the DHHS guidelines. New and emerging therapies are worth discussing, both to compare the benefits and risks of the therapies and to assess them against older therapies that people might be more accustomed to. So just to read a polling question before we start, which of the following is the primary difference between tenofovir disoproxil fumarate, which is abbreviated TDF, and tenofovir alafenamide, which is abbreviated TAF? Is TDF associated with lower renal and bone toxicity than TAF? Is TAF associated with lower renal toxicity but higher bone toxicity than TDF? Is TAF associated with lower renal and bone toxicity than TDF? And then the last option is TAF but not TDF is licensed for PrEP. So I'll give you a moment to think about that and decide on a choice. Here's a timeline of the FDA-approved HIV drugs over the past really almost 30 years now. The initiation of zidovudine was in '87, and we're taking this right up to 2018. So you can see that there's an increasing number of agents on the market every year. I just wanted to focus on the last 4 years to show you what has come on the market recently and put a spotlight on the new ART. And I do realize this is a lot of letters. I've provided the abbreviation explanation at the bottom of the slide. But the ones that have come out in just this year are the fixed-dose combination of Biktarvy, and they also include a new class of HIV medicine, a monoclonal antibody, the first ever approved for HIV treatment, called ibalizumab. So I wanted to emphasize that something that adherence is the smallest possible pill size that still gets the patient the regimen that is going to suppress their virus. And this is a comparative slide showing the relative sizes of all of the fixed-dose combinations and single regimen tablets for HIV. Most of these are really huge pills. The ruler at the top is 2 centimeters, so these are very large pills. Of the single drug tablet, TasP and which is a dual drug tablet, but it's not the complete 3-drug fixed-dose combination. Rilpivirine and Dolutegravir are among the smallest. But taking that into account benefits patients because if they have pill aversion and can't swallow, then they can't get their virus effectively treated. So this is the mechanism of TAF, and the thing to take away from this is that plasma levels of tenofovir, both TAF and TDF are prodrugs of tenofovir, which goes into cells and is converted into the active form, the active metabolite, tenofovir diphosphate, which chain terminates HIV. And plasma levels of tenofovir with TAF are much lower, 10-fold lower than plasma levels of tenofovir with TDF. However, intracellular levels of the active metabolite with TAF are 4-fold higher than they are with TDF. TDF is associated with lower lipid levels. There's an unclear mechanism there, and it's of unclear clinical significance, but it's likely attributed to lower levels of tenofovir seen with TAF than with TDF. TAF is not labeled to be used in people with a creatinine clearance less than 30, and there's very limited data on its use in pregnancy. I did want to mention that cobicistat was a relatively new pharmacologic booster that came on the market that inhibits only CYP3A4, but there's some concern that when compared to ritonavir, cobicistat may have more drug-drug interactions and may boost other drugs in a different manner than ritonavir. They should not be considered exactly parallel. There is a new once-daily formulation of raltegravir that's been approved based on the Once-Merck trial. There's a formulation fix that went into this preparation of a 1,200 milligram daily dosing strategy for raltegravir that was compared in this trial against BID twice-a-day dosing of 400 milligrams and was able to demonstrate non-inferiority of viral suppression, et cetera, studied in combination with TDF, FTC. So the week 96 rates of viral suppression less than 40 copies were 81.5% in the daily group and 80% in the twice daily group, with a non-significant difference between them. So once daily pills have been shown to adherence over twice daily and 3 times daily pills, and so that should be taken into account. Biktarvy, that I mentioned before, the new kid on the block for recommended regimens for first line against HIV, is highly potent. It has a trough level that's 20-fold above levels needed to kill 95% of HIV. and it's useful because it can be given once daily. It doesn't need to be boosted, and the boosters do increase drug-drug interactions with other elements of a regimen. And it is non-inferior compared to Dolutegravir when studied in combination with TasP in a randomized placebo-controlled trial. It's active against variants that can have resistance against the other members of the integrase strand transfer inhibitor class, and it's got a long dissociation constant from the HIV virus. It kind of gloms onto the virus for a long time and creates a high barrier to resistance. It is metabolized, so there are concerns about drug-drug interactions with, for example, rifampin decreasing the bictegravir area under the curve exposure because it induces its metabolism. That sort of thing has to be taken into account, and again, I would strongly urge you to plug new regimens into the drug interactions checker. Ibalizumab, just to focus on this, is a monoclonal antibody that blocks HIV entry by directly to the CD4 receptor on the host cell that enables HIV to enter and doesn't allow it to make the conformational changes that are required for cell entry. It has received orphan drug approval for treatment of people with multi-drug resistant HIV who are out of many other options, and it's active against both a virus that uses the CCR5 receptor and a virus that uses both the CCR5 receptor and CXCR4 receptor, which makes it of higher applicability than Maraviroc, which is only active against the CCR5 virus. It's got a long half-life, so this is injected by IV infusion every 2 weeks. So again, strategies getting away from daily dosing strategies are being embraced, and again, did lower viral load significantly in highly treatment-experienced patients after 7 days of just virtual monotherapy with this. The first lone duotherapy fixed-dose combination is Dolutegravir and rilpivirine, intended to be given to suppressed patients for further suppression of their HIV. Every time you take an element out of a regimen, you have less drug-drug interactions and you lower the cost. So moving towards duotherapy, if they're rigorously studied, it does make sense from both a systems approach and for the individual patients. So this was studied in the phase 3 SWORD-1 and SWORD-2 switch study, where people switched to a regimen of Dolutegravir and rilpivirine from a 3 or 4 drug regimen, maintained their suppression greater than 95%, and none had any baseline resistance, so that's important to keep in mind, and these were all patients who were already suppressed. But this is a nucleoside reverse transcriptase inhibitor sparing regimen, doesn't affect lipids, and it's going to be less costly. One thing to remember about rilpivirine is it has to be taken with a meal. It requires acid for absorption, so it cannot be taken in conjunction with proton pump inhibitors. You can give it with ranitidine and H2 blockers, but you have to space it in time considerably away from them. I wanted to transition to talking about some anticipated new agents from classes that we've discussed before, but new formulations and new molecules. So doravirine is an NNRTI. The NDA, the new drug application, was submitted by Merck in January 2018, and it's expected to come on the market in the fall. And it's a once-daily medicine that really retains strong activity against the most prevalent mutations against agents in the class. And it's been found to have really strong safety and efficacy findings in 3 trials with CAR-related names, Drive Forward, Drive Ahead, and Drive Shift. But non-inferior efficacy and improved safety is of note. Cabotegravir is basically an injectable form and an oral form, a drug very similar in structure to Dolutegravir, but the cabotegravir long-acting is a nanoformulated form that can be given via injection either every 4 weeks or every 8 weeks and maintains viral suppression, as was shown in the LATE-2 trial. Cabotegravir co-formulated with rilpivirine is going to be a long-acting co-formulation, the IM version of Juluca, for potentially people who did well on oral Juluca and want to transition to a less frequent dosing medicine. And again, cabotegravir long-acting will emerge on the market in the next year likely, and is under study not only for treatment but for pre-exposure prophylaxis. It is available in a limited expanded access compassionate use program for those who really prove unable to take daily oral pills. and the link is shown there. And again, more duotherapy on the horizon, going with a theme of eliminating elements from a regimen where 2 drugs will do okay. I'm kind of getting away from that initial idea that a cocktail was mandatory. You still can't really have monotherapy, but there's been really promising results from duotherapy with the cost saving that I mentioned. So the combination of a fixed dose, a combination of Dolutegravir and 3-TC was studied in people who switched to drug maintenance from a suppressive regimen, and 97% of them remained virally suppressed at 48 weeks. So no concerns with resurgence of virus or resurgence of resistant virus because you only had 2 elements in the regimen. So this showed good efficacy in treatment-naive patients as well who had a viral load less than 500,000. Really does remain to be seen whether this is a good option for someone with a much higher viral load. So of interest in the pipeline are a few agents I list here just simply because of their new classes that demonstrate the amount of activity in the drug development space that has taken place in the last 5 to 10 years. So Pro-140 is an IgG4 antibody that binds to the HIV co-receptor that it uses for entry into the cell, and it is active against virus even that's resistant against Raviroc, which is another entry inhibitor. This would be a once weekly subcutaneous injection, so looking for a partner that can also be given weekly would be the issue for just streamlining of the HIV treatment. Fostemsavir is an oral prodrug of an attachment inhibitor, again, preventing HIV attachment to the host cells by binding to a protein on the host cell membrane called GP120. And again, even in people with more than 3 drug class resistance, there was 90% viral load undetectable at 96 weeks in both groups studied. So it was studied against atazanavir, ritonavir. Both had good suppression. Albuterol is a peptide-based fusion inhibitor meant to be given IV every 1 to 2 weeks, potentially a sub-Q eventually, but again, another option for those with virologic failure. So lots is emerging to treat the issue of intractable resistance. So the key takeaways from this talk are really that HIV is prevalent in the U.S. and new HIV infections continue to occur and the issue continues to expand. And these incidences of new HIV are even rising in some groups rather than declining. Young men who have sex with men of color are disproportionately affected. And it's important to do routine screening of people in your clinic to be able to detect those who do not know that they are infected. Guidelines do recommend that ART be started on all HIV-positive individuals. There's no longer any cutoffs for CD4, and they emphasize treatment regimens that include an integrase strand transfer inhibitor and really focus on lowering pill burden, maximizing tolerability, and still not sacrificing efficacy. Products that were approved over the last 2 years include new versions of familiar agents, so same classes, new versions, improving pill burden by lowering dosing frequency, a new duotherapy, and again, a monoclonal fusion inhibitor. Things that we expect to be improved in the next 12 to 18 months include really at long last injectable long-acting antiretrovirals for those who it's going to work better for them to get injections every 4 to 8 weeks than taking daily pills, and the new NNRTI, Duotherapy, which has an extremely high resistance barrier. So now I'd like to turn the program over to Dr. Mona Chitre, PharmD, who is Chief Pharmacy Officer for Excellus Blue Cross Blue Shield, who will begin her portion of the program. Thank you very much for listening.
Thank you, Dr. Weld. I appreciate the opportunity to talk with you about how we in health plans incorporate these new therapies into our formulary management process, as well as how we think about the HIV category in general and the tools and the solutions we have to support our patients. So I'd like to begin with a polling question. HIV is the first, third, fifth, or ninth most expensive specialty drug category. So it is the fifth most expensive specialty drug category. This data comes from Express Scripts' 2017 Drug Trend Report. In fact, it has remained the fifth specialty trend category over the last number of years. And what this really means is that 13.7% of our entire trend is attributed to this one category, behind diabetes, oncology, multiple sclerosis. So it's definitely visible, and it's definitely on the radar screen. And we do expect the trend, as you can see in this slide, to be double digits over the next number of years, and therefore something that we're continuing to think about and solution around. So the issues or the concerns. Our goal in this category is to ensure that our coverage policies provide flexibility in treatment choice as the pharmaceutical advances occur. We always want to have input and review from the national guidelines, from thought leaders like Dr. Weld, as well as from other subject matter experts, to ensure that our formulary and our policies are current and that we focus on treatment adherence to appropriate therapy choice, really to ensure both outcome optimization as well as cost optimization. So with that, this category is still technically regarded as a hands-off category. Unlike multiple sclerosis and diabetes, we don't have the traditional use management techniques that we do, in those categories, such as prior authorization, such as step therapy, such as different formularies. As I mentioned, it is a high-cost category, but with relatively low utilization compared to, again, a condition like diabetes. As I mentioned, most drugs are in Tier 2 or the preferred brand. Our goal is to ensure the appropriate patient gets the appropriate drug for their resistance and for their regimen. And at this time, there has not been contracting. So the pharmaceutical industry has not supported contracting to drive to one category of medications or a specific medication over another. The impact of new branded agents is always top of mind. As was mentioned, single tablet regimens and the new innovations that are occurring are really forcing health plans to ensure that we have access to these medications. And the impact of generics is always something we're thinking about. So generics are available. More and more generics are coming, as I will show you in future slides, but we're very cognizant of breaking apart a regimen and what that can possibly do for patient adherence. As you can see on this slide from the FDA, many drugs were approved for HIV in the last 10 years, and the circled products are those that are single tablet regimens, and the single tablet regimens are those that are becoming the market leaders. As you can see on this slide, as I mentioned earlier, HIV pipeline is robust. It's robust for both brand, which is in the orange category, as well as generics. And that's something we're going to be continuing to think about, of where generics can play a role in formulary management and in containment and patient outcomes. So the medication market share. The market share by class continues to evolve, and you can see in the light blue is 2022 versus a few years ago, 2013, the dark blue. And basically the story of this slide is that the single tablet regimens will dominate the market share go forward. They can improve adherence. They have less pill burden, thus improving adherence, and really becoming the drugs of choice for the future. So in saying that, let's talk a bit about the cost of these medications. The medications range, as you can see on this slide, and the average regimen, the average cost of a patient per year is about $30,000 to $40,000, and that's been increasing year over year. So one of the areas health plans significantly focus on, especially in this category, is around adherence. We know that adherence is critical to optimal outcome for the patient and to reduce all of the other comorbidities and co-conditions that can occur in this population. So adherence is an important component and an important factor in our formulary management and in the consideration of our patients. So based on the PEARL study that was recently published, the results showed that once-daily regimens had lower rates of non-adherence than twice-daily regimens. And thus you can see the single-tablet regimens kind of taking over the market share because adherence is so important. You could read on this slide some of the risk factors for non-adherence in the population. Another study suggests ideal versus typical adherence scenarios. And once again, ideal adherence improves quality-adjusted life years by 1.2 and is cost-effective. So again, these studies are just showcasing the importance of adherence. So what are the things that health plans can do, and what are we already doing around compliance, outcomes, communications with our patients? So first, there are some solutions where health plans are partnering with our health systems around pay-for-performance measures. So there we have incentives around communication with patients, improving adherence in the HIV population along with other populations. Our goals are to strengthen the patient and provider relationships and really empower and educate our patients to ensure that they know the value of adherence and, whatever barriers they may have to becoming adherent. And finally, integrating communication channels, really important. The healthcare system has many, many stakeholders, sometimes some that don't always communicate with each other. So really our goal as a plan is to ensure that all of the stakeholders taking care of our HIV members are communicating with each other. So one, patient empowerment strategies. Our goal as we consider care management is really work through motivational interviewing, talk about the benefits and the consequences, and really have a more of a dialogue with our members rather than kind of talking at them, being didactic. So really patient empowerment and education is key to compliance. As I mentioned, integrated communication channels, physicians, pharmacists, nurses, case managers, not only dialoguing, once a year when they see the patient or twice a year, but really quarterly, much more consistently to improve the outcomes for our patients. So really adherence is critically important as we think about this population from a managed care perspective. The other aspect that we're working closely around is specialty pharmacy. So specialty pharmacy has not been deployed in the HIV arena as much as it has been in other categories like rheumatoid arthritis or multiple sclerosis, but specialty pharmacy is an opportunity where clinically specialized pharmacists can also engage with the patient and the provider as an alternate or as another area of education and collaboration. As I mentioned, we have to ensure that case management is being used more actively, that we're educated on the new regimens, and that we're connecting back and monitoring for compliance as much as with all the data that we have to drive that information forward. So some other strategies that we are looking at, some are used in HIV, some may be used in HIV in the future, and some are just in our toolbox that we've used in the past. The one is benefit management. We'll talk about specialty strategies, specialty formularies. This is commonplace in some of our other specialty categories and may be emerging in HIV, and this is where there are products in different tiers or a specialty formulary, a specialty tier that has higher cost share. Utilization management, as I talked about, prior authorization and quantity limits, not necessarily always used in this category yet, but as the market evolves, if there is contracting in this space, if the generics are viewed as viable alternatives, something that we'll be talking to our thought leaders about. As we look at medical drug versus pharmacy drug with some of the new infusion products entering into the market, really ensuring that there's appropriate awareness through the J-code tools so that we can really monitor the utilization, the compliance of our members, but also ensure that we're optimizing pharmacy channels. Medication therapy management, an area where there's just high-touch connection with our members and our providers. And then finally, contracting. Contracting is an area that we hope to partner with pharma on over time. We have contracts in most other specialty categories. So this is an area that we're going to continue to evaluate as cost continues to be an issue, it continues to be a trend driver, and there's just conversation that will always take place to see how we can ensure access and affordability. So over the last few slides, specialty care management, I talked about this. We can have specialty pharmacy medication therapy management, and you can see some of the benefits and the programs that they can deploy, and then ultimately really connecting all of the trained personnel together, engaging and empowering and educating our members so that we can have optimal outcome. As I mentioned before, benefit designs. So benefit designs and specialty tiers are growing. It currently, as per EMD Serono Digest that was accessed from February of 2015, health plans are increasing their multi-tier specialty cost shares. And as such, the opportunity for HIV to be managed in this sort of manner increases. And what that can mean is that there are generics, brands, and then non-preferred brands in these specialty tiers, and clients have the option of creating specific copays for those formulary bands. So that's something that is an option, has not really been impactful to HIV, but could be in the future. Key takeaways is that HIV from a managed care perspective has been fairly hands-off, but it is still high visibility. It is still top 5 in our trend, and it's changing. There's pending generics. There's more single tablet regimens, potentially an opportunity to contract with the pharmaceutical industry. Adherence will always be top of mind. Our goal is to improve clinical management and clinical integration, and then ultimately all of the stakeholders need to be involved to improve the outcomes and manage the cost and trend of this patient population. So as a final thought, new drugs are entering the market, and cost containment continues to be top of mind in this top 5 specialty trend arena, and there will be issues that continue to be needed to be addressed. However, we balance always the needs of the patient, ensuring the resistance profile, the comorbid conditions, the side effect profile, the adherence solutions are thought through as we consider the formulary management technique. The favorable safety profile of TasP has been reflected in the evolving IAS and DHHS guidelines. Single tablet regimens are reflected in the guidelines and are expected to be the market leader. The new agents that are entering the market are also single tablet regimens and appear to be highly efficacious with limited toxicity. And the goal is that people who have HIV can now expect a close to normal life expectancy, and our commitment and collaboration and education of these patients is really critical, as adherence is key to that life expectancy. So with that, we thank you for your time, and we'll open it up for question and answer. Thank you for joining the live question and answer session. Our first question today is for Dr. Weld. Are there any disadvantages associated with the new 2-drug combination that is available for people who are already suppressed? What about breakthrough resistance or any other issue with the drug?
Yeah, so that's a great question. Thank you for bringing this up. So as we covered in the program, the advantages of a 2-drug regimen from the perspective of eliminating one extra component that might have its own side effects and certainly has its own costs are substantial. And these drugs have been studied in patients who are virologically suppressed, who are switched to this regimen, and they do succeed in keeping them suppressed The two-drug regimen of dolutegravir, rilpivirine, has a pretty robust, pretty high barrier to resistance. However, if you're a person who does have adherence challenges, it might be wiser to be on a regimen with 3 components just to kind of provide more backup. And the other caveat is, if you're someone who had an extremely high viral load and challenges in getting it down, this might not be the best regimen for you, just given that rilpivirine-based regimens should not be used in people who had starting viral loads above 100,000 because of concern for virologic failure. But overall, this is a good option for if you've achieved virologic suppression and you are tolerating, a regimen but are interested in coming down on too many components in a regimen, and this has been studied for exactly that. It does a great job at achieving virologic suppression. In terms of resistance, resistance is always a concern if adherence is suboptimal. So if you have kind of just enough drug around in your system to basically give your virus selective pressure to develop mutations against elements of your regimen. So if you have resistance in your virus and you continue taking a regimen that your virus is resistant to, that's not going to be a good situation. So being carefully monitored while on a 2-drug regimen, as you would be on a 3-drug regimen, would be important.
Great. Thank you, Dr. Weld. We have a few more questions for you. The one that just came in, do you personally have preferred drugs for pregnancy, for women who are pregnant, avoiding Dolutegravir, or patients who are of childbearing age, any preferred medications for them?
Yeah, so it's a good question. So just to start up front with the reference to dolutegravir, so as I mentioned in the presentation, there's been recent concern raised by a trial in Botswana where 4 of the participants had infants who had fairly severe forms of neural tube defects, and they were on dolutegravir-containing regimens. And this was a background rate that was 10 times higher than in the other arm of the study that were not taking dolutegravir-containing regimens. This is a very preliminary finding and needs to be looked at further in terms of understanding, is this actually a signal? What is actually happening here? Are there other explanations for this occurring? What was the folate supplementation like in both arms, et cetera? So this needs to be looked into. The current guidance is if you're already pregnant and you're on a dolutegravir containing regimen, you should continue it because these instances all seem to occur at the moment of conception. So if you were on dolutegravir when you conceived, that's when there is an issue. Obviously, very, very early in the first trimester is when neural tube defects occur. So if you're a woman of childbearing age who is, thinking of conceiving or is of pregnancy potential and not on a reliable contraceptive, it does make sense potentially until this finding is understood and explained better to avoid dolutegravir. Other regimens that do make sense in pregnancy, there were early concerns about efavirenz based on some animal data, but very well done large meta-analyses later of efavirenz in pregnancy have found that this is safe. There's a lot of evidence that is accumulated about the use of efavirenz in pregnancy. It's highly effective at keeping viral load down and preventing maternal to child transmission, which is a priority of treatment of HIV in pregnancy. And so, in a sense, efavirenz is a good regimen as well. There are many other options that can be used in pregnancy based on the individual case as well.
Great, thank you. Another question we have I can respond to. So how important are the HIV adherence measures in CMS Medicare stars to your plan? And HIV has a higher threshold. Their threshold target is 90% compared to other chronic diseases at 80%. So the adherence measure, STAR measures in general are very important to health plans. They drive a lot of our quality activity. They drive, how we are perceived in the market by our community, by potential enrollees. So STAR measures are very important, and we focus on virtually all of the STAR measures, adherence being a very significant priority for us. So all adherence measures and all STAR measures have focus. The pharmacy division specifically spends a lot of time on adherence, where we have dashboards. We are running data continuously to ensure that we're identifying patients and their providers who may need a little more support. So it goes back to some of the comments in my discussion related to medication therapy management, related to conversation and collaboration between the provider, the pharmacist, the health plan to improve a adherence rate to meet a STAR measure, a quality outcome, and ultimately appropriate goal for each patient. So it is very impactful, and we're aware of this particular STAR measure, and it drives focus and activity. So I think we have time for one more question. So the question here is, what other drug combinations are being studied for PrEP? I don't know, Dr. Wells, would you be able to respond to this question?
Yeah, sure. So there is a large study currently ongoing looking at TAF-FTC for PrEP. And until that study completes, we obviously can't be using TAF-FTC for PrEP, but that is being studied to try to understand if that has an equally protective effect against transmission of HIV, which for TDF-FTC, if taken consistently as prescribed, the protective effect is as high as 99% protective. So TAF-FTC is being looked at. Dolutegravir, or rather long-acting cabotegravir, is being studied for PrEP in large trials through the HIV Prevention Trials Network that are ongoing. Obviously, any trial that looks to show a protective effect of an antiretroviral against acquisition of HIV needs a very large sample size of patients, just because it's a fairly rare event, and needs to balance kind of how high risk the particular population is. So those two trials are ongoing, and there are other PrEP kind of prevention technologies that are in earlier phase study as well.
Great, thank you. So I think, we may have time for one super quick last final question. Dr. Wells, some of the regimens have to be taken with meals, not just snacks. In your opinion, what's the simplest regimen, the one with the fewest restrictions?
Yeah, so a regimen that does not have any food restrictions is a good idea. Things that contain, for example, rilpivirine require acid in the stomach. So, food with decreased acidity is taking them at the same time as acid blockers is not recommended. And there's some regimens that are very indifferent to the spacing with food. Generally, it just comes down to, looking at the package insert for each individual regimen. But I generally think of dolutegravir-based regimens as fairly indifferent to when a meal occurs. I don't know if Dr. Chitre has other insight into that, but I definitely feel that the fewer restrictions with respect to food, the better, because people's lives are complex and meals happen frequently, and being able to take their pills just when they have them in that moment is key.
Yeah, I would absolutely agree with that sentiment and comment. And so with that, we're at the top of the hour. Thank you for your time and your attendance. If you could please complete your post-test and evaluation to ensure you get credit, that would be great. Thank you very much.
Thanks so much.